Good morning and welcome to the Houston Methodist DeBakey Heart and Vascular Center Grand Rounds interview. I'm very excited today to host Dr. Navin Kapur, who has given a phenomenal Grand Rounds just a little while ago, and hope everybody caught it and you can use this forum to ask questions. On the screen you should have instructions to send in questions, and as the questions come in we'll tackle them. But Navin, I'd like to welcome you to the Methodist DeBakey Heart and Vascular Center, and everybody has been enthralled and excited about your visit of the paradigm changes, and it's really a paradigm change, the concepts that you're building. I think I'd like to start off asking, how do you envision, if what you envision is going to be positive in the trial and it will execute it, what do you hope to achieve to change this disruptive progress in the care for STEMI patients?
Yeah, so first of all, thanks so much for having me. It's been great to be here, and as I said in the Grand Rounds, it's an honor to be here, given the legacy of Houston Methodist and all of the work, pioneering work that's been done by the surgical teams here, as well as the advanced heart failure teams as well. And at the fundamental level, the door to unload trial is really a heart failure trial. We talked about in the Grand Rounds a little bit about the concept of in-hospital mortality reductions with Mission Lifeline and some of the really successful programs designed to reduce door-to-balloon times. And we've certainly reached a point where we can now get door-to-balloon times on average of 60 minutes across the United States. The systems of care are in place. But as a heart failure doctor, I think one of the things that we continue to see is this rising growth in heart failure patients. And the number of patients is increasing, and a lot of that is coming from ischemic cardiomyopathy, which still remains, one of the major causes of heart failure. And when we started to look a little bit more closely at the question as an interventional heart failure person, my area of interest was to look at whether or not we can change the trajectory of someone's life by first going after not post-MI remodeling, which is where a lot of the drug and device therapy has been focused, but actually in that upfront infarct remodeling and preventing the subsequent post-MI remodeling from ever even occurring. And so that's where this concept of looking at mechanical unloading, and as we also talked about in the Grand Rounds, this has been around for a long time. It's actually not a new idea. The surgeons for many years have been doing this, and even back in the 1970s, pioneering work was done by a number of investigators, including here in Texas. Richard Smalling's a great example of someone who started to look at early acute mechanical unloading as a method to reduce infarct size. So the door to unload trial, the pivotal trial, is now finally we've reached a point where we have the engineering capability to rapidly deploy a microaxial flow pump into the ventricle. It's a device, the Impella device has been well established, the safety profile exists, broad clinical exposure in the high-risk PCI and cardiogenic shock arenas is already there. So it actually is just a really good timing for a trial like this, because the technology exists, the concepts have been around for a long time, and now the two are coming together in the pivotal trial. And really, the pivotal trial, as we talked about, is two arms, door to unload and door to balloon. The important takeaway message from the Grand Rounds is that both arms are targeting ischemia in the setting of an occluded LAD artery. And the purpose of the unload arm is to reduce that ischemia by targeting the ventricle and then the coronary, whereas in door to balloon we target the coronary and we don't ever address the ventricle. And so I think if the trial, even just executing the trial successfully, will already change the paradigm, because it introduces the possibility of now changing the treatment prioritization to ventricle first, coronary second, as opposed to coronary first and no attention to the ventricle, which is what we currently do for our STEMIs.
You're a small group of people in the country who are dual boarded in interventional and heart failure. And certain perspectives you talked are really key to stress to the audience that the fact of the heart attack and MI still are at high odds of ending up in heart failure. Even though as a public health entity, hypertension contributes to the number of cases, if you have an MI, you have a high odds of ending up with heart failure on the long term. And your last slide was very telling that by going so upfront and blocking the injury, you could theoretically wipe out heart failure incidence in these patients on the long term. So do you foresee like a major public health importance of this concept of unloading at some point that hopefully will change the incidence of heart failure per se?
Yeah, I mean, I think that's the holy grail, is the idea of, we talk a lot about myocardial recovery. There's been a lot of talk about myocardial regeneration, but those are, regeneration is sort of post-injury, and, I think, that's a later term approach. By going up front at the time of injury, if we focus on the mechanisms that are driving the injury, yes, I do think that if we're able to reduce infarct size, we would reduce the burden of subsequent post-infarct heart failure. And, the concept for interventionalists is relatively new to be focusing on a heart failure endpoint for a STEMI trial. But, one of the landmark trials in 2019 was the COAPT study. And the COAPT study really started to meld the worlds of interventional and heart failure, a percutaneously deployed device-based strategy for a heart failure problem with heart failure endpoints in the trial. And so when you look closely at the DTU pivotal trial design, actually, even though the primary endpoint is still infarct size, which I think is the fundamental biologic plausibility for subsequent efficacy endpoints, and that's why it's the primary endpoint, but the secondary endpoints all start to target things like heart failure hospitalization, ICD-CRT burden for these patients. And that ICD-CRT burden is a really great example of attenuating the maladaptive remodeling process. And if you think about the cost associated with ICD, CRT, the drug therapy for heart failure, late-term advanced device therapy for heart failure, all of that is built early based on that early injury. So if positive, there would be potentially huge healthcare implications, cost implications, would change the field quite a bit. I think, and that's ultimately the dream, the holy grail is to help our patients by preventing them from ever having to deal with heart failure in the first place. But I think, right now we're still at a very early stage. There are a lot of hurdles to overcome, to get to the pivotal, and certainly the pivotal itself will require a lot of attention to detail, because now we're talking about a device-based approach for remodeling at the time of injury. And that really is early phase work.
Oh, remarkable. I think we have some questions that have come up, and let's see. The first question is, how do you envision the concept of unloading to translate to patients with RVMI and then to cardiogenic shock in general?
Yeah, so that's a great question, and I think some of the work that's being done currently, there's a lot of concurrent work being done in unloading and cardiogenic shock, and we've seen that in a lot of prospective registry work, the NCSI database from Bill O'Neill, the work from the INOVA shock group, starting to suggest that algorithmic approaches that focus on hemodynamic assessment and early mechanical support may improve outcomes, especially for AMI cardiogenic shock. And I think that work will continue to grow. The door to unload link to that work is based on the same platform of unloading. And I think it's also important for folks to understand that unloading is something that we do all day, every day in our patients who have any cardiac dysfunction, but it's usually done with a drug-based approach. And so that's where, now we have a paradigm shift. And AMI is a great, substrate for that. But door to unload, the trial does not involve patients with shock, and that's an important distinction from the shock work. In terms of RVMI, this is a fascinating area. We've talked a lot about this, and predictive modeling for who develops RV failure and the RVMI outcomes. We know if someone develops cardiogenic shock with RVMI, it's just as bad as having an LAD anterior MI shock. And I think that the concept of unloading to reduce infarct size may not make as much sense in the RVMI patients. It's a thin-walled ventricle. The likelihood of developing true transmural infarct in the RV is quite rare. But developing RV dysfunction And supporting the right ventricle early in the setting of RVMI before they develop profound cardiogenic shock, I think is really important. And there, using devices on the right side to mechanically unload the RV wouldn't necessarily change infarct size, but certainly could change outcomes for the patient, such as mortality. The last thing we want to do is ignore an RVMI that has an elevated CVP. And I think we talked a little bit about this at the shock dinner last night, about the importance of venous congestion and targeting right atrial pressure. So not quite door to unload for infarct size reduction, but related on the spectrum of cardiogenic shock and unloading.
Yeah, and I think I like what you talked about, and I always say in the cardiogenic shock realm exactly what you mentioned, that for decades in shock, we've forgotten the left ventricle and we douse people with a bunch of pressors, more importantly thinking about cerebral perfusion, kidneys, liver. But the concept of unloading, as much as we need to prove it in the regular shock setting, makes sense because you want to rest the ventricle.
Right.
And in that regard, in the area of unloading, do you think there's a difference in unloading with a transaortic pump with unloading the LV versus unloading from the left atrial side with a transseptal pump? Because both unload the LV, but I do see in certain areas that the energetics might be different. Do you have any insight into how we should unload the pump? Unload the LV?
Absolutely. So there, the tandem heart device has introduced the concept of percutaneous left atrial unloading. The Impella device is sort of the transvalvular direct LV unloading device. And for many years, actually, we had studied the differences between LA versus LV sourcing for a pump. And if you think about LA-FA bypass, which is the tandem device, it does work in the sense that it can unload the ventricle. The challenge is that the amount of unloading is dictated by the size of the left atrium. And as a result, the left atrial volume is smaller. So even if you have a large bore cannula in the left atrium, if you inherently unload the left atrium, you'll get a suction event and you may reach a limit of how much you can unload the LV. And then the second component of that is that by displacing the blood from the left atrium into the arterial system, there is still that pressurizing of the arterial tree, and there's always that slight chance that you might not reduce LV systolic pressure, but you will reduce LV diastolic pressure. So that is a unloading approach, but it can be just technically limited by LA sourcing. Now, LV sourcing is different, and even if you were to put a cannula into the LV, transvalvularly, and remove volume from the LV directly, that will be a more efficient way of unloading the ventricle. And whether you do it with a microaxial flow pump or an external centrifugal flow pump, that is probably the best way to unload. And of course, that's where all of the durable LVADs, really focus. And any attempt, to try to do LA sourcing for a durable ventricular assist device hasn't really panned out, again, because of some of the limitations of LA sourcing.
Yeah, and I think you bring up a point when we are supporting patients with support devices. It's not like a pump is a pump is a pump. Each pump has a different physiology.
Correct.
And you want to make a mindful effort in picking which one for that physiology, and that's actually very well thought out and put forth. We have another question, which says, as presented, all of these experiments and studies were made on anterior wall MIs. So what about inferior MIs, and where preload is one of the critical aspects of management? So I think you kind of touched upon RV, but maybe will this apply to a circ lesion? How do you foresee this?
Yeah, it's a great question. The reason we're focused on anterior MI is that the anterior MIs have the largest area at risk. And to really just show that we are reducing infarct size, that is the high price real estate is the anterior wall. Those patients, we know there's been a lot of data from previous studies and trials that allow us to do comparative analyses, et cetera, to understand how to design the trial. I think the closest we can get to left circ or other non-LAD territories is if you look at multi-vessel PCI. And the recently published COMPLETE trial looked at STEMI patients and looked at complete revascularization in those patients and showed that actually in STEMI patients, if you do complete revascularization within 45 days of the incident MI, that those patients have a better long-term prognosis. And so one of the questions is, for left circ lesions or non-LAD territories, do we think that ventricular unloading has the same benefit? The answer is, my guess is yes. because just biologically, it's still mechanistically in that same direction. But the magnitude of the infarct reduction would be greatest with anterior MI. And in the door-down load trial, one of the questions that will also be part of the trial is, do you completely revascularize now that you're on the platform of an Impella device, where we know for many years people have been doing protected PCI successfully, and that also has implications for improving ejection fraction and clinical outcomes for patients. So will we see that their operators start to have a different behavior once they're starting to do STEMIs in an unloaded state? And I can tell you from participating in the pilot trial, a lot of our operators felt like they were more comfortable once the heart was unloaded. And the operator themselves started to feel more relaxed, more willing to take their time with opening the artery, making sure they have optimal LAD stent deployment. And then, the question does come up, if there's a neighboring lesion that could also be addressed, is it better to do it at the time of the STEMI when you're unloaded? Or is it better to bring the patient back for yet another procedure? And I think that question still remains to be answered. It's not something we'll definitively answer in the pivotal trial. But this question of non-LAD territories is still open. But mechanistically, I think there's a benefit.
And you touched upon this in your case, and I don't know if all the audience caught it, and you mentioned it in your question, that the patient that you showed had an LVDP of, I think, 20 or 24, but once you unloaded, you're very comfortable giving beta blockers. And you alluded to it, so there's this whole space of adjuvant therapy, because we all talk about resting the heart, but if you're in an MI and a shock situation, or you're tenuous, we don't want to give beta blockers. That whole paradigm has changed. So what are other medications that you see surfacing back with being able to support the heart to go even further optimizing the myocardium?
Yeah, I think it's a great question. And if you look at all of the variables that could drive myocardial oxygen consumption, heart rate is actually one of the most powerful and potent mechanisms by which you increase myocardial oxygen consumption. So whether it's beta blockers, whether it's another drug-based approach to regulate heart rate, we're seeing it somewhat in the neuromodulation space a little bit, not so much with acute MI, but the idea of door-down load is that by implanting the device, we now all of a sudden create a window in time where previously you didn't have time to do anything other than open the artery as quickly as possible. But because we've gotten so good at doing that, and because we have the technology now to unload and rest the heart, and based on the pilot study, we know that it's safe and feasible to wait 30 minutes without increasing the infarct size, now all of a sudden the possibilities are opening up for new avenues of investigation, where on the platform of unloading, could we do what our surgeons do and administer cardioplegia? Could we administer a cocktail of therapies that are designed to target heart rate, target blood pressure, optimize calcium handling in the ventricle? There are a number of potential candidates. So I think at minimum, if the pivotal trial doesn't show any sign of adverse effect with regard to infarct size, then it does open up the possibility now of studying combination therapies of drug and device to try to really maximally optimize myocardial biology in the setting of STEMI.
Yeah, fascinating, because I think now you have an opportunity to rest the heart, right, more than flogging the heart with all the medications that we do in a very effective manner. And I think that's probably a great paradigm moving forward. Now, do you foresee that this concept of unloading, and if you think about some of the experiments DeBakey did, with the DeBakey pump, it was partial assist with a descending aortic graft. In the field of unloading, do you see these percutaneous pumps where you actually partial assist the pump, the heart, and rest it for a period of time, not just in an MI setting? Is that a concept that you think will be reality in the next decade or few decades, that people can go home with an implantable Impella, get neuromodulation medication or gene therapy, recover the heart, come back, and then just get their pump explanted?
Yeah, there's no question that the field of unloading science is going to rapidly expand, I think, over the next few decades. The number of devices that are coming out in this space is also growing. And not only the number of devices, but also the really creative approaches that are out there to try to target ventricular load. And a great example is the neuromodulation work. Again, targeting heart rate. The vagal nerve stimulators, I think, are a great example of that. I think the idea of having a partial assist device, there is likely a dose response to the reduction in infarct size and ventricular unloading. So I do think the more unloading you can achieve, whether it's device-based or device or drug-based, and the combination probably really would get to the ultimate unloading, that you would see more benefit. And I think that the idea of doing partial assist for longer-term support is really interesting, and it came up in the discussion today at the Grand Rounds because the surgeons are the ones who have been unloading, and when they're unloaded, they know that actually at that point they've already started treatment just by simply going on pump. And the term going on pump for interventionalists doesn't really exist, yet we do it hundreds of times a year, and we go on pump, and all of a sudden the way we approach the patient changes. So what we're saying is that, for the surgeon, going on pump and then taking your time to reperfuse those vessels is natural to them. And the question we get asked mechanistically is, why are you rushing to reperfuse from the surgical community? And in fact, the idea of having an implantable device and then unloading the ventricle for a prolonged period of time, is emerging as a reality. I think we will get to a point in the next decade or so where, not so much for the STEMI population, but for the heart failure population, where we start to see non-ventricularly directed therapies, meaning that we're not apically coring out the ventricle or putting in a transvalvular pump or other approach that would stay in for a period of weeks to months, and create another opportunity where you've created a window in time for a patient for an advanced heart failure patient to make better decisions about candidacy for transplant or VAD, for durable VAD. So I think that is coming as a reality, and we'll see all sorts of new approaches for ventricular unloading.
Oh, that's great. I want to remind our viewers, if you just joined, that you have instructions on the screen to submit your questions, and we have here Dr. Navin Kapur, who has given us a stellar grand rounds on some paradigm changes in unloading the heart. Navin, one of the things that always comes up in today's world is cost. And I know the focus to me, conceptually, unloading in a STEMI setting has a potential to probably decrease cost because you have an incident downstream effect of decreasing the incidence of heart failure, as you said, decreasing need for VADs, transplants. But I want to ask you, as a thought leader in cardiogenic shock space, and we run into these issues where I call it shifting risk, where we have accountability of certain programs like transplant and VAD, where you're monitored for outcomes. And as much as in the desire to save patients, yesterday you were alluding to it, we go through escalation of mechanical support, trying to see if we can make them better candidates for VADs or transplant. But I also foresee that the cost is shifting, where we're investing a lot in acute devices, where people are getting Impellas, ECMOs, and after months of trying to rehabilitate them, we might be failing. So my question to you is, do you foresee that we should organize the shock programs and have it a mandatory quality oversight so that you monitor and invest in processes that monitor outcomes along with cost accountability, so you constantly refine it? Do you foresee that happening at a national level as a mandate?
I think it has to happen, is the bottom line. The challenge, however, is that cardiogenic shock remains so poorly understood, and it's a multifaceted, complex syndrome as opposed to a single entity problem. And as we know for cost effectiveness studies, in order to do that analysis, you have to have effectiveness. Then you can look at cost. And if you take the example of VA ECMO, the challenge there is massive growth in VA ECMO implementation, major costs associated not so much with the technology, but with the resource allocation to manage patients on ECMO. The effectiveness of VA ECMO is not well established, no randomized trials. We also know from the registry data, the German experience was recently published in Circulation, that there's still 60% mortality for shock patients supported with ECMO, whether it's MI or heart failure. So I think the challenge is that, yes, there is an intense amount of resource and cost associated with mechanical support, But until we have a better way of looking at the shock entity itself and approaching it in a different manner, and I think some of the work that's being done now to apply algorithms, so for example, the INOVA work is, I think, really pioneering, because application of an algorithm, which includes multiple potential device platforms, but then showing an improvement in survival from 40 to 80% in 1 year for AMI shock. Now that really makes a statement. It suggests that if you have the correct algorithm tailored to the right type of shock, which is AMI shock, you can change outcomes for patients. And now the cost implications of that, I think, are going to be interesting to look at, because we finally have some data suggesting efficacy in AMI shock, and the NCSI data also supports that concept. For non-AMI shock, advanced heart failure, where resource allocation goes on and on, that I think is going to be a much more challenging substrate to sort out. But I think we're getting to the point now where we're starting to see the benefit of early mechanical support for AMI shock, changing outcomes for patients in a short amount of time. And that is where we can do some really good analyses on cost implications. And my guess is that if you're getting to these patients early enough and you shut down the injury mechanisms, the subsequent rehospitalizations, et cetera, is something that needs to be looked at. But data needs to be generated. In order to generate the data, we have to have a much more rigorous understanding of the problem. And I think that's where our focus right now is in cardiogenic shock, is defining the problem and the various subtypes of shock and how to tailor the therapy for those patients before we can do cost effectiveness analysis.
I think you bring up a valid point, and maybe we forget sometimes that the data in shock is so lacking, and if you think about it, mortality is bad, and when we're putting in these devices, there are times where we say, oh, their risk is so high, but their alternative risk is probably 0%. If you don't, even though, to your point, 60% mortality with an ECMO, if somebody needs an ECMO, their survival is 0%.
Correct.
But at the same time, we have not learned enough to predict futility. And I think you've done some fascinating work in the machine learning that you're doing. Can you tell us a little about the database that you're working on, a multi-center database on cardiogenic shock?
Yeah, so we developed a cardiogenic shock working group. It was born out of frustration. This idea of, we use all the technologies at Tufts Medical Center. We've had phenomenal outcomes with VA ECMO, and we've also had great outcomes with Impella and Tandem Heart in the past. And we know that balloon pump, for example, we still use in our advanced heart failure population. But the frustration is born out of not knowing the algorithm for each of the patients. So a few years ago, in 2016, we started a working group to collectively come together and understand the entity of shock. And then in 2017, we decided to embark on the development of a registry. It's now including 15 centers in the United States. We have over 2,500 patients worth of data. But unlike any other registry for cardiogenic shock, we include all acute mechanical support platforms. We are really providing real-world evidence across multiple types of centers: community hospitals, academic, advanced heart failure, VAD, transplant centers. And the third layer is that we have hemodynamic data in the registry. And that really allows us to better characterize the cardiogenic shock entity with over 1,100 patients out of 2,000 in the first round of analysis. So the shock working group has now really gained a lot of momentum. We are expanding our sites now up to about 20 sites. There's interest from international sites to participate. But the focus is to provide scientifically rigorous analysis of the entity of cardiogenic shock. And the first two reports coming out will focus on the application of the proposed SKY staging system for cardiogenic shock, and to look at whether or not that staging system can predict in-hospital mortality. Our data suggests that it does. And then to look at a granular look at the hemodynamic profiling of shock patients, where we learn that elevated CVP actually is one of the most important markers of poor outcomes for patients in shock. The second analysis will focus on a machine learning approach, where we take our bias out of the equation and allow for an unbiased characterization of a large data set to then start to create clusters or phenotypes of cardiogenic shock, and then validate that in a cohort, which we've done in Denmark in partnership with Jacob Moeller and his group, and then start to look at who are these phenotypes. And we've identified 3 phenotypes of shock in the first analysis that are distinct in their clinical variables, but that are directly associated with mortality in 2 separate cohorts. And I think work like that is informing certainly my practice, but hopefully it will inform the general public focused on cardiogenic shock, so we can identify tailored approaches for the correct phenotype of shock. And I think that's where we are right now in the space. If we're successful in identifying and defining shock, I think we could develop randomized controlled trials that are tailored to specific entities where we avoid the futility patients, and we also avoid the patients who probably didn't need the intervention, maybe too early, the pre-shock terminology, and we actually start to look at the correct shock patients. And I think the AMI shock data that's coming out from these groups is really suggesting that we can do it. We can move the dial.
Yeah, I think that's some great work. We have a few more questions here. I think one of it you touched a little upon last evening when we were talking on what would you propose, and this is a gigantic task, and you're already getting people to the table from different spheres of the healthcare sector. So the question is, if you could propose collaboration between clinicians, researchers, professional organizations, and industry, how would this look like for this space of MI and heart failure?
Yeah. So the good news is that there is a template for that. I think Intermax was very successful in starting off as a registry, adapting that with NIH, FDA, industry, clinician buy-in, some very rigorous data scientists to help with an analysis. And as you know, Intermax really did move the dial in our understanding of the entity of durable mechanical support for heart failure. And an example of that is taking the stages of heart failure and then applying Intermax profiles. And while a lot of that initially was very subjective characterization, we in the shock space can learn from that. And I think that there is going to be a national mandate at the federal level for the development of a shock registry that's national. At this point, my request is that there should be NHLBI focus, and there should be funding, a request for funding applications or proposals from all of the investigators in the U.S., like yourself and myself, who are interested in the space of shock. It should be at the R01 level to really drive rigorous peer-reviewed science in the space. And if we can do that, I guarantee you the caliber of publications coming out in shock will increase, and also we'll start to move the dial towards developing the correct types of trials. So I think it's definitely doable. I think payers will be very interested in this because it's a huge problem, as we talked about healthcare resource burden. And right now, it's still an art, and it's not a science. And I think that's something that can change, especially with NHLBI support.
Oh, that's great. And then you brought up the distinction of our past concepts of an acute MI and what you define as a success in opening up the artery or door to balloon time. With you leading this space, what would you define as success for a patient who's coming in with an MI when you're trying to treat them?
You mean in terms of timing elements, or? In
general, what would be a successful intervention? How would you measure yourself saying, I did a good job by treating this patient with MI?
It's a great question. I think, and this question actually came up at the TCT meeting, and there was a lot of focus on the coronary vessel. And is the success opening the vessel, having no reflow, good hemodynamic data? At the end of the day, the success is measured by the patient. And if the patient, first of all, tells me they're feeling better while I'm applying a therapy, that tells me we're in the right direction. If the patient continues to do well and subsequently after their STEMI presentation is now resting, not in heart failure during that index hospitalization, never progresses to develop cardiogenic shock, is discharged from the hospital with already showing signs of improvement in the ejection fraction, and then is seen in the subsequent clinic for their follow-up and doesn't require the intense amount of post-MI remodeling drug therapy and doesn't meet criteria for an ICD at the follow-up evaluation, I think those are all the metrics that we would look for. And especially if that patient goes back to their lives, gets back to their rigorous activity workload, enjoys their life, and doesn't come back with heart failure for many years. And I think that would be our metric of success. It all focuses on the patient.
I think that's a very good vision to have. End of the day, I think to your point, patient-centric outcomes for the long term makes perfect sense. Another aspect that you touched in your presentation is this myocardial blood flow. And I think one of the aspects of improving, I guess, the collateral myocardial flow is by decreasing your LVEDP. But do you think there's something to the fact that in an Impella device you're pushing blood into the aortic root? Is there any evidence that actually your epicardial flow in the non-occluded artery could be pushing into your collaterals as just a physical concept, apart from opening up the collaterals through the gradient?
Yeah, this is a really fascinating area of physiology that's now really coming to the fore. There's been a lot of phenomenal work with pressure wires, with calculating fractional flow reserves. Coronary flow reserve always been a research tool, trying to look at Doppler signatures. There's a group of investigators being led by DeBakey Pereira in the UK, looking at wave intensity analysis and energetics of flow, forward and backward expansion waves. And we've partnered with them in the preclinical work as well as in the clinical work, trying to understand the impact of balloon pump, Impella, tandem, ECMO, et cetera. And what we learned actually is that when you're under ischemic conditions, autoregulation of the microcirculation is uncoupled. And when autoregulation is uncoupled, that means that as you increase pressure into the epicardial vessel, there's a response where autoregulation is activated to maintain a mean arterial pressure in the microcirculation. But if that's uncoupled, then there is actually the potential for increasing microcirculatory flow without necessarily changing epicardial flow. And so that's where we actually are beginning to see that in our work, and this was just recently published in JAHA, looking at collateral flow index. And the collateral flow index tells us whether or not the distal pressure inside the area of muscle subtended by an occluded artery, we want to call it the coronary wedge pressure, for example, if that starts to increase despite the fact that the artery is occluded, it starts to suggest that there's an increase coming from collateral flow into the area at risk. The other thing too, though, is if we take a step back, many years ago, decades ago, there's a lot of physiology about just the impact of wall stress on myocardial perfusion. And in fact, as soon as you reduce ventricular wall stress, myocardial perfusion is increased. And if you were to simply increase, even if you had high aortic root pressure, but if the ventricular wall stress is increased, microcirculatory and myocardial perfusion goes down. So I think the target of therapy to improve myocardial perfusion is to reduce wall stress. And however you do that, with an Impella, with a tandem, whatever mechanism to reduce ventricular wall stress, you should see increased myocardial perfusion. And we are beginning to see that even using the latest tools of wave energetics and collateral flow index in this latest analysis that's coming out.
Oh, that's great. I think we've had a great time hosting you, and you've really enlightened us and our center and the whole world into this whole progressive thinking. And we wish you really good luck in this endeavor, and I think you're going to be you're leading a disruptive progress, and we wish you good luck for changing the paradigms of care for STEMI patients and cardiogenic shock patients in general.
Well, thanks. It's been a pleasure being here, and again, I always learn with these interactions. And again, it's an honor because the disruption actually is based on a lot of fundamental work that has occurred in places like this. So thanks again for hosting me.
Thank you. That's awesome. That's good.